Good morning, everyone. I'm Stephanie Maselli, Media Officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us for our webinar for the recently released report, Respiratory Health Effects of Airborne Hazards Exposures in the Southwest Asia Theater of Military Operations. And you can download the report and related resources at nationalacademies.org/Gulf-airborne-hazards. And the slides and recording of this webinar will be available on that page as well. For those of you who are not familiar with the National Academies of Sciences, Engineering, and Medicine, we are private nonprofit institutions, and we provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, committee members are chosen for their expertise and experience, and they serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the entire committee, and they must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report, but before we jump in, just a few reminders. This webinar will be 1 hour. We'll start with a presentation summarizing the report by our committee, and then we'll open it up to audience Q&A. If you have a question, you can simply click the Q&A button on the bottom of your screen and submit there. And should you have any technical issues during this webinar, you can contact Zoom technical support at 1-888-799-9666 and select option 2. Now I'd like to introduce the members of the committee that wrote the report who are here with us today. We have our committee chair, Dr. Mark Utel from University of Rochester, Dr. Meredith McCormick from Johns Hopkins University, and Dr. Sperry Vidal from the University of Washington. And with that, I'd like to turn it over to our committee.
So, good morning. It's a pleasure to join you this morning and to brief you on the committee's report regarding the respiratory health effects of airborne hazards exposures in the Southwest Asia Theater of Military Operations. The Southwest Asia Theater of Military Operations included involved 9 countries, and the health report and the health study addressed both the 1990-1991 Gulf War and subsequent post 9/11 operations. The Academy has previously provided a number of reports to the VA. Next slide. So deployment to the Southwest Asia Theater puts service members at risk to a variety of airborne hazards. And as listed here, there are exposures associated with military operations, burn pit emissions, a variety of gases and particles, as well as diesel exhaust, and these are detailed in the report. There are occupational exposures, and there are regional environmental exposures, including air pollution from local and regional sources. So the charge to the committee was to comprehensively review, evaluate, and summarize the available scientific and medical literature on the respiratory health effects of exposure to airborne hazards encountered during service. The committee was asked to pay particular attention to the hazards associated with burn pit exposures, to look at excess mortality, cancers, a variety of respiratory symptoms and diseases, and in particular constrictive bronchiolitis. And finally, to look at emerging evidence on respiratory health outcomes in service members from the major veteran studies that were either completed or in part ongoing. In brief, the charge was really to evaluate the extent to which the existing data and the database informed our understanding of the potential adverse effects in terms of in-theater military service on respiratory health, to identify gaps, to consider research that could be feasibly undertaken to address some of the outstanding questions, to look at and to discuss newly emerging technologies that might be helpful, and finally to consider organizations that VA might partner with in accomplishing these tasks. So the committee members included a broad range of expertise. There were experts in epidemiology, in environmental and occupational health, in the area of exposure assessment, military and veterans health, and in addition, of course, in statistics. And the outcomes that the committee addressed were kind of categorized as follows: the non-cancer respiratory disorders, including upper airway disorders, non-infectious lower airway disorders, interstitial lung disease, respiratory symptoms, and infectious lower airway disorders. In addition, we looked at respiratory tract cancers. And finally, we looked at what we'll call other outcomes, changes that might have occurred in pulmonary function, and finally, total mortality and mortality due to disease of the respiratory systems. So I'm now going to turn it over to my colleague, Dr. Meredith McCormick, an associate professor of medicine at Johns Hopkins, who will really who will take us through this evaluation of the respiratory health outcomes. Meredith.
Thank you and good morning. For each of the respiratory health outcomes that Dr. Utel just outlined, the committee reviewed the evidence, weighed the evidence, and placed each into one of 4 categories. And these categories have been used in prior VA-sponsored reports. And they include categories where there was sufficient evidence of an association between in-theater exposure and the respiratory outcome of interest, where there was limited or suggestive evidence of an association, a category where there was insufficient or inadequate evidence of an association, and then finally, where there was limited or suggestive evidence of no association. The committee's evaluation was based on the literature and on the methodology in each of the studies reviewed, and some of the considerations included the sample size of the study design, the presence or potential for bias in the study design, as well as methods used for exposure assessment, as well as health outcomes assessment, and then the appropriateness of comparison groups, as well as the potential for confounding. And one of the confounders we'll describe is the presence of smoking. So for the category of sufficient evidence of an association, that was defined by where the sum total of the literature would suggest that there was a positive association between in-theater exposures and a respiratory health outcome, in which the studies in total, there was minimal chance, bias, or confounding that was felt, and it was felt that these influences could be ruled out with a reasonable degree of confidence. There were no outcomes that met this criteria for the classification. We look at the classification for limited or suggestive evidence of an association, and this was defined by where the sum total of the literature suggested that there was an association between an in-theater exposure and a respiratory outcome, but there was an inability to really confidently rule out chance, bias, or confounding. And the committee found that for respiratory symptoms, which were defined by persistent chronic cough, dyspnea or shortness of breath, as well as wheeze, that that outcome met criteria for limited or suggestive evidence of an association between in-theater exposures, both during the 1990-1991 Gulf War, as well as among those who served in the post-9/11 conflicts. Thinking about respiratory symptoms, studies that were previously reviewed by the National Academies and in those reports were relatively consistent in reporting associations between deployment and increase in prevalence of self-reported symptoms. The outcomes that were reviewed among more recent studies were largely in line with these prior findings, including results of the 2019 examination of the Stampede cohort. Most of the studies, or many of the studies considered, were weakened by the presence of bias, which was included the self-selection of participants who may have sought care for their respiratory symptoms, by self-report nature of symptom outcomes, by the nature of the fact that individuals have to report their symptoms, as well as the lack of controlling for potential confounders, which included cigarette smoking, which is known to be have an increased likelihood of known to be associated with the presence of respiratory symptoms. In reviewing the studies, these concerns were noted and were taken seriously, but the sum total of the evidence was still found to rise to the level of suggestive of an association. For the category of limited or suggestive evidence of no association, this was defined by the instance where there were several studies which covered a full range of exposures and did not show an association or potentially showed a reduced risk of an association between the exposures in theater as well as the health outcome. And one outcome met this criteria, and that was deployment among the 1990 to 1991 Gulf War veterans and changes in lung function. The studies that the committee reviewed were largely consistent with those findings of prior National Academies reports and were uniform in finding no association between exposure and changes in lung function. This differed when we looked at the evidence of the post 9/11 veterans and those exposures and the outcome of changes in lung function. And for that body of evidence, the committee found that there was insufficient or inadequate evidence of an association between exposure and changes in lung function. The committee noted in reviewing the literature that there were several limitations of the studies, and that included the fact that the analytical methods often did not include the assessment of within-person differences in changes in lung function, that there was often absence of comparison groups, and that there was limited follow-up time between the exposure and the subsequent change in lung function. The lung function findings reviewed by the committee have been used by some to argue that that there's no role for surveillance spirometry in those being deployed to or returning from theater, particularly those who are asymptomatic. Such arguments have been based on concerns about cost as well as measurement reliability and the very low frequency of detecting abnormalities in those individuals who don't have symptoms or don't have pre-existing respiratory conditions. The committee noted that these concerns are valid, but there remain important outstanding questions that pertain to the role of surveillance spirometry. And these questions were aggregated to three overarching questions. And these are whether pre-deployment spirometry may be useful in detecting those at increased risk of deployment-related respiratory problems. Also, whether pre-deployment spirometry could be used to assess post-deployment respiratory symptoms and problems, and whether surveillance spirometry may have a role in studying and documenting the long-term or chronic impacts of in-theater exposures on lung function, subsequent lung health. Studies to address these questions would require some form of surveillance spirometry, and in light of this, the committee felt that and put forth that the value of surveillance spirometry remains an open question. And finally, for the category of insufficient or inadequate evidence of an association, all of the remaining respiratory health outcomes that were displayed on Dr. Utel's slide earlier, examined by the committee, fell into this category of classification. And some of the limitations that were identified in reviewing the literature included those in terms of inadequacy of exposure assessment methodology, limited availability of some of the pertinent health outcomes, including physiologic indicators of respiratory health, as well as lack of information related to behavioral components that were known to be important, such as smoking, as well as lack of biomarker data. There were also limitations in the study populations, which included often the case of self-selection, as well as relatively low participation rates. And another limitation was the amount of time that had often passed between exposure and assessment of the health outcome. The committee emphasizes that these findings do not mean that there is no association between deployment to the Southwest Asia theater and respiratory health outcomes, but rather that the available evidence doesn't allow a more definitive determination about this potential association. Returning to the statement of task, the statement of task included an ask of the committee to pay particular attention to the hazards associated with burn pit exposures, as well as assess areas where there are known knowledge gaps and research that can be feasibly conducted in the future to address these outstanding questions and to generate answers. The committee was also asked to identify newly emerging technologies that could be incorporated to aid in these efforts, as well as organizations that the VA might partner with in the future. As far as the hazards associated with burn pit exposures and burn pit emissions, the committee found that there's relatively little evidence addressing how burn pit exposures may result in adverse respiratory health outcomes. Other than the self-reported airborne exposures and health information that were collected as part of the Millennium Cohort Study, as well as the Airborne Hazards and Open Burn Pit Registry, there have been no large-scale deployment systematic efforts to collect data or maintain a data registry with specific regard to burn pit emissions. The committee did identify a means to gain a better understanding of this issue going forward, and particularly noted the 2011 publication and the work that was done in the long-term health consequences of exposure to burn pit exposures by the committee that was published in 2011. This was identified as a potential template that could serve going forward to outline how we can address gathering data on this in the future. The committee did note, though, that it's been about 10 years since this was published, and there are new technologies and approaches that should be incorporated going forward. To think about the other aspects of the statement of task, I'm going to turn it over to Dr. Vidal, Professor Emeritus from University of Washington.
Thank you, Dr. McCormick, and good morning. As you heard, one of the statements of task for the committee was to identify gaps in knowledge, and some of the general categories of gaps are listed on this slide. Of course, we have gaps in our understanding of the adverse respiratory health effects in theater veterans, and we'll touch on that, and Dr. McCormick has already summarized some of the evidence related to that. There are major gaps in our understanding of in-theater airborne exposures, and understanding those is extremely important. We have limited understanding of actually the biology behind the airborne exposures from theater. And then finally, biomarkers have been touted to be very useful measures of both exposure and health effects. But we have very little information on the validity of these biomarkers in this context. Regarding the exposures, which I alluded to as being very important, we know that there are hazardous exposures, but we have limited information on who was actually exposed, what they were exposed to, where and at what concentrations they were exposed to, over what time, and how frequently exposure occurred. We have very little information on the very specific contaminants that comprise exposure. Even using substitutes or proxies for exposures, such as where a person was, their proximity might have been to certain sources, even those types of data have been extremely difficult to obtain. And then even for a very relatively specific exposures, such as burn pit emissions, we know that those emissions were very highly variable, both in terms of how much the exposure was there and also what the composition of that exposure was, which varied over time and place. The committee, in light of that, the committee recommended some things be done, and rather than just throwing up our hands and saying more research is needed to be done, we hope to make some more constructive recommendations that could be done that for research that could be feasibly undertaken, and also so many of whom that could be completed in a relatively short, over a relatively short time frame. So there are a number of areas where we had made some suggestions with respect, first of all, to constrictive bronchiolitis, for which there's been a great deal of interest, understandably. General mortality and respiratory mortality specifically. The other outcomes that Dr. McCormick listed, for which we had assigned evidence categories of being inadequate or insufficient. The issue of susceptible subpopulations, understanding mechanisms, importantly, the retrospective characterization of exposure, which I'll touch on, and then also some suggestions for new studies that could be carried out that would be over the longer term. Now, with respect to constrictive bronchiolitis, this is an entity which has garnered a lot of interest, and justifiably so, in this context. It is a disease of the small airways, of the bronchioles, and requires that there be fibrosis or scarring in the small airways of the bronchioles, as well as possibly inflammation. Now, there are uncertainties regarding constrictive bronchiolitis in the context of in-theater exposure. First of all, one that came up is that really what is required on a lung biopsy in order to be confident in making the diagnosis. In addition, the data on constrictive bronchiolitis come exclusively from a series of case reports. And the issue there is, rather than being in a formal study, can they be used to attribute exposure in the Gulf to the reports of constrictive bronchiolitis? And then a related question is whether, in fact, the diagnoses of constrictive bronchiolitis occur more frequently than would be expected in the general population. To address this uncertainty, the committee recommended that the VA establish an expert panel to advise it on the issues related to the diagnosis of constrictive bronchiolitis in veterans. Now, this slide shows one of the areas of uncertainty having to do with the lung biopsy. So on the left, we have a normal small airway. In the middle is an airway of a patient with constrictive bronchiolitis, and on the right is a normal airway that has not been sufficiently inflated. Now you'll see that the middle one and the one on the right bear some similarities. That is, they have a thickened wall as opposed to the one on the far left. You'll see in the middle, however, there's that big area of red in the cartoon depiction, which is meant to depict scarring or fibrosis. And that is missing in the normal airway in which there's inadequate inflation. And one of the concerns has been, and the uncertainties has to do with the diagnosis of constrictive bronchiolitis based on poorly inflated airways that could be confused with the middle picture. Next slide, please. Now, the recommendations for this panel were that this panel be external to VA, both for the purposes of ensuring some consistency in reading slides, and also to address issues of perception of impartiality, which would be, I think, critical for a panel like this. We recommended the expertise should largely be pulmonary pathologists, that is, people who are experts in looking at slides under the microscope, but also include expertise in pulmonary medicine, toxicology, epidemiology, exposure assessment, and radiology, and also include representation from the veterans community. The charge of this committee or panel would be to develop specific guidelines for VA's evaluation of theater-deployed veterans in whom the constrictive bronchiolitis is being considered as a diagnosis. The specific tasks of the panel, as we envisioned it, in addition to reviewing slides of cases where bronchiolitis is suspected, would be to determine the adequacy of lung biopsy approaches and recommend best practices, make recommendations for the processing, handling, and storing of these biopsies, and then finally to create criteria for confirming the diagnosis, criteria based on the pathologic slides. Next slide, please. Another area where we thought that would be done over the relatively short term was having to do with mortality or deaths due to respiratory disease. Now, the first two paragraphs provide some detail in terms of when the last studies on mortality were completed, and the take home from that is it's been a while. It's been many years since these studies have been done, and there's some value in having new studies done in that there are more people who have died in the interim, and in addition, some of the effects on mortality take a while to evidence themselves or to manifest themselves. So a more recent or up-to-date analysis is justified. So the committee recommended that VA conduct or sponsor an updated analysis of mortality in veterans. And we understand that, in fact, such studies are underway currently and might have results available in the relatively short term. Now, we emphasize that to improve upon the previous studies, in addition to the lengths of follow-up, it would be important to try to improve upon the estimates of exposure. When people were deployed, pre-existing health status, for example, and also personal information. And as Dr. McCormick mentioned, cigarette smoking would be an important one. So those would be preferable things to supplement these mortality studies. Next slide. There were a number of conditions for which the committee assigned an evidence grade of inadequate or insufficient. And we felt that there was potential for progress to be made in these studies over the relatively short term. First of all, by improving estimates of exposure historically, that is in the past, to make use still of studies that have data currently. In addition, there are opportunities for supplementing the studies with more subject-specific information, such as smoking, but also other things as well, where they were through other records. Biospecimen data are available for subsets of the population that could be made use of. And then supplementary outcomes such as some measures, physiologic measures and radiologic or imaging measures could be used to supplement these studies. The issue of susceptible populations was raised, and we have very limited information on which subgroups of the population might be more susceptible to exposure in theater. There are data that are collected for this purpose, but have not been utilized. In addition, for future studies, it would be important to identify potential measures or potential conditions that would make one more susceptible, and one of particular interest is asthma. Some others are listed at the bottom of the slide that would be valuable. And then with respect to smoking, many of the studies did not either control or did a poor job of trying to control for the effects of cigarette smoking. In addition, there's a lot of interest in e-cigarette use currently. There's largely basically no information with respect to e-cigarette use in this context. And then biomarkers of smoking. They are available. Some have been available for years. Some are currently still evolving that could present opportunities for better assessment historically of smoking exposure. Next slide. The issue of mechanisms of exposure effects is valuable to know about. And so the committee was interested in having toxicology or animal studies carried out. First of all, they enhance the plausibility of the exposure effects, in addition to providing insight into how exposure actually affects a person. We did make a couple of observations on how we'd like to see these studies done. First of all, with exposure being reflective of the actual realities of exposure in theater, that is using realistic exposures. And in addition, looking at clinically relevant outcomes would be important, I think, rather than, as often is the case, looking at specific markers that reflect certain mechanisms of disease, but aren't really directly indicative of clinically relevant outcomes. Next slide. The important issue of exposure characterization was on the committee's mind a lot, and it is critical to have good estimates of exposures in doing some of these studies. Now there's very promising research that's being done on it, and some of it more than promising, in fact, is underway currently. Biomarkers can be used for that purpose. There was excitement about using satellite-based remote sensing of concentrations in order to provide both spatial and temporal resolution of exposure to pollutants such as particulate matter, which is of special interest. And some of these studies are actually underway now and applied to data from the Gulf War theater. Specifically regarding burn pit activity, one could repurpose remote sensing observation from fires from the NASA database. Next, please. Now, the committee did put forward some study designs to provide some insight into the types of studies that would be needed in the future to provide definitive answers. These studies focused on COPD, or chronic obstructive pulmonary disease, as an example, and highlighted the need for both pre-deployment and post-deployment measures of lung function in that setting, combined with, as we mentioned before, better measures of actual exposure in theater. Next, please. Now, the committee was under no illusions as to how feasible these types of studies would be, and there are reasons why they might not be feasible. First of all, pre-deployment lung function is typically not available, and so if one were to do this, one would have to do pre-deployment lung function on prospectively or looking toward the future. Probably more importantly is the fact that there are now far too few service members being deployed to the Gulf in order to mount an informative study. So these limitations or challenges present some issues for policymakers that they need to weigh if they're going to commit to supporting future health studies. Next, please. Now, finally, there are a host of technologies out there, newly emerging, as well as some that are fairly established, that can be used in prospective studies or looking to the future, that assess, first of all, exposure, and also others that assess health outcomes. With respect to exposure, we've itemized a few of them there: silicone wristbands for organic compound measurement, some other wearable samplers, self-sampling devices that can collect and store data for use and analysis in the future. For health outcomes, we're all familiar with smartwatches and the advances that are being made as we speak in what they can measure. There are other devices, some that measure lung function, add-ons to on-body communication devices for other physiologic measures, other portable devices such as exhaled airway gases that can be used to reflect airways inflammation, and others. I'm going to end there and pass it back to Dr. Utel to complete our presentation this morning.
Thank you. As I had mentioned, recognizing, VA recognizing some of the limitations in prior studies, they asked the committee to look at who might be reasonable partners going forward in terms of trying to address some of the remaining questions. And in addition to the Department of Defense, NASA and NOAA were of particular interest because, as has already been mentioned, there's satellite imaging going on that can then be used for modeling for ground level exposure. And as we've repeatedly indicated, exposure limitations limit confidence in making or excluding associations. The Department of State actually is doing some measurements for ozone and particulate matter in selected areas. NIEHS has interest in biomarkers, and especially if VA were to pursue some of the pulmonary function studies that have been considered, NIOSH has a real experience in terms of collecting and analyzing pulmonary function data. Clearly, the VA has partnerships with DOD, and they're likely to be important going forward. One area that we've heard about is an electronic record, health record system, which would be integrated between VA and DOD, and this would have the potential to allow the investigators, again, assuming there's proper human subject assurances, to more easily access these data for research purposes. It would simplify monitoring of respiratory health over time. There would be one system in place. And the committee strongly recommended that VA and DOD explicitly integrate research access considerations into their planning of what's going to be collected in the electronic record, and implement these kinds of strategies into the electronic health record system. DOD and VA should commit resources to developing the necessary database for research studies so that they can be in place as this integrated system goes forward. And VA is well aware of the usefulness of the partnership with DOD in other environmental health areas. There's programs with the Defense Health Agency that is capturing military, occupational, and environmental health risk data from biologic, chemical, and other health hazards. The EILER system is moving ahead, and this would provide a record of service of the service members' occupational environmental health exposures over the course of their career, linking what is known about their exposure events and incidents and compiling it into an exposure history. And finally, as was mentioned, there are a number of DoD biorepositories as one is looking at retrospective type studies. These biorepositories may be very useful in providing information related to respiratory health outcomes in veterans. So in concluding, the committee recommends that VA continue and expand its partnership with DoD on environmental health issues, focusing on the flow of information on exposures encountered during the military service, and then linking that with health of the personnel before, during, and after deployment, as well as once the transition is made to veterans status. This kind of leveraging should be incorporated into the health research programs that are ongoing, the Million Veterans Program and the Millennium Cohort Study. And finally, this should include cooperation on identifying the respiratory health status information that needs to be collected so that it's available for use later on, perhaps as the baseline data that would be available for relating the veteran's need for treatment, as well as potential benefits and, of course, research purposes. So in conclusion, given the limitations that we've heard about in the existing literature regarding respiratory health effects of exposure to the airborne hazards in theater, the committee basically felt that a new approach is needed that will allow researchers to more fully examine and answer the questions of whether certain respiratory outcomes are indeed associated with deployment. This new approach is not one that's intended to support the common theme that more research is needed, or to suggest that only alternative is to undertake work that will take lots of years to produce meaningful results. But rather, again, as you've heard, we believe that well-conducted epidemiologic studies are possible today using retrospective designs that allow one to better account for confounding variables and factors, in particular smoking, to combine and analyze existing data in innovative ways. Also, it'd be important to standardize outcome ascertainment methods, how the data is collected, to allow for better comparability of results. At times, it was very difficult to compare results from one study to another. And finally, there are opportunities as satellite imaging becomes available, and there is some work going on at doing that precisely to estimate retrospective exposures. So next slide. That pretty much brings our presentation to closure. As was mentioned, the information on the study is online, and the report can actually be read online and downloaded at no cost. So with that, the committee'd like to thank you and would be available to answer questions.
Thank you. And we'll have the National Academy staff read off the questions. Just as a reminder, you can submit those in the Q&A box at the bottom of your screen. And if you are so inclined, feel free to share your name and affiliation.
So we have a lot of excellent questions from the web, and I want to thank Doctors Utel, Vidal, and McCormick for their lovely presentation of the report. The first question that we got on the web is the VA found, and I think this was answered during the presentation, but just to reiterate it, the VA found that satellite weather imaging and air traffic control measures of particulate matter on the ground correlated closely. Using this method, the exact service member locations could be correlated with actual conditions on the ground those days. Would this be helpful?
So let me take the first stab at that, and both of my colleagues may want to contribute as well. But for sure, we're all thinking along the same lines here in that given the technology that has evolved and the opportunity to look at levels of pollutants and to go back and look at some of this from the satellite collections, and then to model ground level exposures, and even at times, as mentioned in the question, members' locations, this will be very helpful, and indeed, or it should be very helpful. And indeed, there are at least one study that's trying to look at this relationship between satellite conducted measurements of exposure and health outcomes. Sverre or Meredith, anything else you'd like to add to that?
Yeah, I might add. I mean, I think it's a good question. I think this is a question that probably knows this this area has advanced considerably in recent years, not just using sort of weather satellites, but all kinds of different satellites for assessing concentrations of pollutants, in particular particulate matter or particles. In addition to that, marrying those data with air quality models, with ground level monitoring, that is, this fusion approach has even been more powerful. And I think, as Dr. Utel alluded to, I mean, those that are carrying out these studies are using, I think, a number of different approaches fused together in order to piece together exposure. I mean, one of the challenges in that, and that was included in your question, was the issue of the location of specific individuals. And that sometimes has presented a challenge. So that issue will need to be grappled with as this work proceeds.
Okay.
Sorry, I was just going to add that a related question that came up during a briefing yesterday was about how long would these further studies that the committee has recommended, how long do you think that they would take? I just thought I'd ask that now because it adds on to this.
Sure. Dr. Vidal answered that yesterday.
Yeah, I think one thing I left out yesterday in my discussion with this, and it is an important one. I mean, there were sort of three areas of where we could look at studies being providing data fairly quickly. The first being the mortality studies that were mentioned, that really just require accrual of more up-to-date data. As mentioned in the presentation, it would be nice if those studies utilized better measures of exposures that had been utilized in the previous generation of those mortality studies. But even short of that, updating the mortality studies would be valuable and something that could be done in the relatively short term. The studies, I mean, we'd think they can be done very quickly, but they end up taking a little bit longer than one would suspect. But they all are underway currently, so one would think that study of mortality at least might be available within a year. Other studies, the ones that I think we were excited about trying to supplement exposure or to enhance exposure with very much more spatially and temporally resolved information, I think would likely take a little bit longer, but even those types of studies applied to many different endpoints, existing endpoints, and data on existing endpoints could conceivably be done within a 1 or 2 year period of time. the committee on constrictive bronchiolitis that we had recommended, some of the products of that committee could be available fairly quickly, such as guidelines and on interpretation of biopsies and approaches diagnosis of constrictive bronchiolitis, the ongoing activities of the panel, reviewing biopsies, reviewing slides and such is an ongoing process. But so I think at least in those three areas, information should be available quickly, at least in this relative time frame.
Along the lines of better exposure assessment for particulate matter, Jay Malott asked, regarding PM exposure especially, should the better effort to catch individual exposures during deployment been qualitative, i.e. mass of PM, and or also qualitative, I think they mean quantitative, with some chemicals of the PM also monitored, and which of them, nickel, vanadium. So I think they're asking about, you know, determining what actually makes up the PM. Would that have been more useful? Is my paraphrase of that.
Let me throw this out to Meredith and Sverre and see if they want to start, and I'll add to that. Meredith, any comment?
Sure. I think when we discussed this quite a bit in terms of thinking about ways that in the future we could use emerging technologies, or emerging technologies could be applied for exposure assessment. And this question of quantitative versus qualitative, or PM, for example, exposure, just in terms of the mass amount versus what's actually the composition of the PM. And so some of the comments that have made already regarding silicone bands would be one example, or biomarker data using human specimens, where you could actually look at an individual level exposure to different chemicals, which may be contained in particulate matter, would be examples of ways that different technologies could be applied to marry that concept of absolute level exposure versus what's in the dust. And that came up a little bit yesterday as well, acknowledging that there's different levels of evidence for natural sources of dust versus part of dust that comes from combustion and other activities. And so I think there are more nuanced questions that could be asked about chemical composition, and we should look to the future for technologies and ways that we could look at individual level exposure.
Good. Sverre, anything you want to add to that?
Yeah, I agree with what Dr. McCormick said. I think one perspective we should have on this is not to get ahead of ourselves. We still have a lot of work to do in terms of assessing and trying to understand individual level exposures to air pollution generally, particulate matter generally, and the other perspective on this would be really the progress or lack of progress that's been made in that regard in the myriad of studies that have been done on particulate matter and particulate matter concentrations. It's been very challenging, and so even though the data may be available and such, I think it's sometimes perhaps a little unrealistic to think that we're going to make a lot of headway in understanding the specific composition of exposure effects very, very quickly. At least taken lessons from all of the work that's been done more generally in air pollution up to this point.
And maybe to add one other aspect that the committee did spend a good amount of time talking about are some of the practical constraints in terms of doing exposure assessment, for example, looking at the levels of particulate dust that a soldier might be exposed to, and some of the challenges of doing that type of work in the field really will need to be considered in the future as well.
Yeah, so two points. We did hear from the veterans community in terms of actually wearing some of these monitors, the weight and the inconvenience. But as we're going forward, this technology to put it on your wrist, or a very light and extensive kinds of monitoring that can be done going forward may change that. But at least in the past, there hasn't been a lot of systematic monitoring of particles or components. And then I would add to just what Dr. Vidal said, with all the studies that have been done on particulate matter in the US and worldwide, we're still looking for the silver bullet in PM that explains the broad range of adverse effects that have been seen. And in fact, there's still debate, is it PM 2.5 alone, or are the coarse particles important, and are the ultrafines a component of that? And so that debate, when one begins to look at components, we're probably not very close to having good answers on what it is in the particle mix that's responsible. Okay, Liz, I think we'll turn it back to you.
So switching gears from exposure assessment, the next question I wanted to read is Millet says, I'm a nurse case manager with Navy Special Warfare. Has there been data collection from Special Operations Forces from the Special Operations Forces community? Her experience includes a number of warriors with lung cancer, sinusitis, and chronic cough, and all were exposed to a variety of airborne hazards during the post 9/11 conflicts.
Any takers on that, on the special forces? So we looked at this question separately, and as far as I'm aware, there aren't a lot of studies on the special forces, and so the committee did not really deal with that specific issue.
I think I might add one thing is related to your sort of latter point. I think the committee experienced a general sense of frustration given the testimonials that we heard and obvious interest in seemingly outcomes that, for example, asthma in theater or other issues, some of which you raised. But the data did not support it, and that was a frustrating aspect of our work on this committee, where we sort of strongly suspected associations, but the data were not strong enough in order to lead us to conclude that there were associations.
Liz?
Yeah, sure. I was just checking if anyone else had anything to add with that. Let's see. This is from an anonymous attendee, and they said, is there going to be any DoD VA coordination of follow-up of existing efforts regarding discovery level biomarker work? Is there are there any thoughts on funding or supporting movement into human studies? So I think they're asking about understanding biomarkers of exposure to air pollution, or maybe biomarkers of early effect.
So I don't think we can comment on what DoD and VA plan. We would point out that there's the potential to do some of this certainly within the biorepositories. There are samples that have been collected for years and years, and there are refrigerators full of these or freezers full of these samples that would potentially allow for that kind of investigation. There are lots of privacy issues along the lines that have to be considered, but there are specimens that are potentially available. Anyone else want to comment? Okay. Next question.
Ronald Brown asks about, this is jumping back to the satellite data, and he said that's a great recommendation for the current war fighters or the fighters for the more recent conflicts in the region. But what about the 90-91 Gulf War? Were the satellite imaging data available? Is there any way that that could help veterans in that cohort?
I don't know the answer to that. Meredith or Sferry, any sense of when the imaging became available?
Yeah, I think the early generations of satellite imaging do extend back that far. Not the more sophisticated ones that we see now that allow more detailed, more spatially resolved data, as well as some better pollutant concentration data. But in terms of, for example, particulate matter, there is an historical record that would go back that far. And that would be useful.
Thank you.
And I know we're up on the, we've passed our time today, and it looks like that is all the time we have for questions. So I do apologize if we didn't get to every single person. But once you exit this webinar, you will be redirected to the study page where you'll be able to download the report, all the materials, and follow up and ask any questions. So once again, I'd like to thank our speakers and thank all of our attendees for joining us today. Have a great rest of your day.